Hello, all dear friends, my teachers, myself, Dr. Sampat Dumbre patil. I am practicing orthopedic surgeon in Hadapsar, Pune, and my area of interest is foot and ankle. Today is the first talk of MOA Master Series, a great initiative by our executive committee and our MOA president. I thank them and Dr. Ashok Sham for inviting me to talk on heel pain, which is really a common issue faced in our OPD practice. Now, in next few minutes, we will be talking on how do we evaluate heel pain and how do we manage it. We know roughly it is 10% of our population who will suffer from heel pain in their lifetime, and it amounts to 1% of all visits to orthopedic surgeon only for heel pain. So it's quite common. We are looking at a problem which is common in our day-to-day OPD practice. But why there is a confusion? Still, patients continue to have heel pain, and we as consultant, we are still having no answer for this heel pain. Either we are putting all causes of heel pain in one basket of plantar fasciitis and treating it, or we are not diagnosing the heel pain properly. Let us see how we can uh, find out a solution for this. Are we evaluating it completely? Let us see what are local causes of heel pain. Plantar fasciitis, fat pad atrophy, calcaneal stress fractures, compression of Baxter nerve, tarsal tunnel syndrome, calcaneal tumor, infection, so many other causes other than plantar fasciitis. Calcaneal stress fractures are seen commonly in athletes as well as few people who are doing overzealous exercises or increasing exercises in short amount of time. Tarsal tunnel syndrome is also seen, and sometimes infection or tumor may be the cause of pain. Some systemic causes: seronegative arthritis, rheumatoid arthritis, gout, ankylosing spondylitis, Reiter's syndrome, or various collagen disorders may be causing pain in heel. So many times when we take X-ray and see heel spur, we label heel spur to be the cause of pain. But 50% of patients with heel pain have heel spurs, or vice versa. Only 5.2% of total patients with heel spur, they report to have heel pain. So that may or may not be the cause of heel pain in every individual with heel spur. Few other conditions like base planus or cavus foot deformity may be contributing factor, so as tight Achilles tendon. Of course, don't forget to examine spine for radiation in distribution of L5S1. Now look at these pictures. Clinically, we can diagnose so many conditions, like I'm palpating gastrosoleus muscle, and now my index finger is pointing at the musculotendinous junction. Any pain around here is non-insertional tendinitis, or muscular tendinous junction pain. Here it is a tendon which I am palpating, which I should be palpating the thickness, elasticity. This is insertional part of tendon, and I am just palpating anterior to it, so I will be able to diagnose pre-Achilles bursitis. This is where I will diagnose post-Achilles bursitis. Now, this is proximal plantar fascia on medial side. So, tenderness around here will be plantar fasciitis, and this is a distal part of plantar fascia. This is squeeze test for heel to diagnose the stress fracture of calcaneum, and sometimes even patient they complain of pain on lateral side or medial side. On medial side, it is may be due to tarsal tunnel syndrome. Ask the patient to show with one finger where it hurts most. If it is on posterior aspect, it may be around Haglund's protuberance, or it may be on plantar aspect in plantar fasciitis. Now look at this patient. This patient has on right side normal Achilles and hollow on either side of normal Achilles, but left side where there is heel pain, this patient has fullness on either side of Achilles. So we are definitely dealing with some kind of synovitis or bursitis which is around Achilles area. Look at this patient on right side, there is a big bump of bone which may be in the tendon itself, or it may be Haglund's tendon or bursa. So clinically we can diagnose so many conditions. This patient is indicating pain just below the lateral malleolus, and when we took X-ray, it was osteophyte arising from subtalar joint which was projecting posterolaterally to cause pain just below the lateral malleolus. So, so many conditions can be diagnosed by careful clinical evaluation, and then investigation modalities will just be for confirmation. Further imaging will confirm your clinical findings. You may take standing AP and lateral views on X-ray to find out tumors, osteomyelitis, fractures. Bone scan may be of help in case of some of the stress fractures. MRI will identify pathological entities like plantar fibromatosis, tumors, or infection. Ultrasound may be of help in knowing the plantar fascia thickness, or it may give you some idea about the fat pad. Of course, blood investigations to diagnose connective tissue disorders or rheumatological diseases will be done. One interesting investigation is serum TSH. I find so many times hypothyroid women having pain in heel very often, and it may not be the cause, but may be an associated factor. Neurological evaluation in terms of EMG or NCV may be required in case of tarsal tunnel syndrome. Now, how do we treat this condition, heel pain? It should be dictated by etiology of pain. Plantar fasciitis, how do we conserve? In fact, non-operative treatment is the mainstay of managing plantar fasciitis. Initial acute phase rest, cast, some anti-inflammatory medicines, and then physiotherapy with stretching, orthotics, or steroid injections are mainstay. Stretching and physical therapy is most important part of conservative treatment. Now, it involves stretching of Achilles tendon as well as plantar fascia itself. And it, it has its own protocol of passive movements, stretching, mobilization, strengthening, and then proprioception and gait training. Physios may help you to stretch the Achilles because even tight Achilles reflects into plantar fascia and heel pain. This is how Achilles stretching along with plantar fascia stretching is done passively, but even active strengthening is also advocated. Some other modalities like hot water fomentation, ultrasound, taping, or matrix may be of help. This is how plantar fascia stretching is taught to the patient. Different ways to do Achilles as well as plantar fascia: simple towel, which is given to do the passive dorsiflexion at the ankle, or standing on stairs. Rolling a bottle which contains cold water is also of help, or for strengthening, we can try to um, pull on the handkerchief on the floor, or pebbles you can put it in a glass. Wall exercises I like to teach myself to the patient so that they know correct way of stretching, and if done correctly, this is one of the most effective exercise to have gentle stretching of Achilles as well as plantar fascia. See that when you do this stretching, the hind foot should not be in external rotation alignment. It should be straight in line. Some other orthoses like soft heel may be of help along with night splints. Some patients, they have the profession where they stand for a long time, and again they are predisposed to have heel pain, and that's why activity modification also may be suggested. Steroids, clinicians often give steroids, and evidence says that steroids may provide relief, but effects are temporary in majority of patients. You have to treat rheumatological diseases if they are there, and usually they are started with NSAIDs or maybe disease modifying drugs. If it's neurological, that is maybe tarsal tunnel syndrome, then it may not respond to your conservative treatment of plantar fascia. And then along with other conservative measures, you have to give some more medicines, or think of uh, the from where the neurological compression is. Extracorporeal shockwave therapy is one more helpful therapy in the conservative management, where a different frequency um, machines are used, um, other than which are used in urology. So this is also effective way of treating resistant kind of heel pain, particularly plantar fasciitis. What is surgical treatment? What are surgical options? First, we recommend non-surgical treatment, and if sincere efforts are done to undertake conservative management, and since it is, even if it is not working for 6 months or a year, then you suggest patient for surgery. But more than 90% patient, they respond to conservative treatment, and patient should be explained complications of surgery. What are surgeries? It may be a partial release of plantar fascia open, or it may be done endoscopic as well. In open plantar fascia release, uh, we uh, take care of the medial neurovascular bundle, and do it by open procedure like this, and release of deep fascia is important when you protect the nerves. Another case where we have released the plantar fascia from medial side, endoscopic plantar fascia release is also possible, and topaz therapy, which is radiofrequency ablation, well, multiple um, coagulation is done at the plantar fascia with a probe which is minimally invasive. So this topaz therapy may be also of help. So to conclude, various local and systemic conditions cause heel pain, which is other than plantar fascia. So diagnose them individually and treat heel pain on its merit. It is not that every heel pain is plantar fasciitis. Conservative treatment is successful in most of the patients, and surgery will be required in few. Thank you so much.
Thank you very much, Sampat sir, for this first webinar on office orthopedics. And I'm sure many of us has learned a lot from this talk. Thank you very much, sir, and we look forward for another talk with you soon. Thank
My
you.
pleasure. My pleasure. Thank you.